now we have I think the last session for our conference today. Doctor will introduce Dr. Saad Al-Talhab, Professor, Consultant Dermatologist, former Dean, College of Medicine, Al-Imam Muhammad Ibn Saud Islamic University, Riyadh, Saudi Arabia. Welcome, Doctor, for our conference.
Thank you, Doctor. Thank you for this introduction. So we will be presenting today about melanocyte keratinocyte transplantation in vitiligo versus other disease. So as we know that patients with vitiligo usually they are suffering from this disease for long duration as it is autoimmune disease, but one of the solution is melanocyte transplant. So nothing to disclose. So as we know, that vitiligo is an acquired autoimmune disease that is causing hypopigmentation or depigmentation in patients, and it affects almost 1% of the population. And the psychological burden of this condition is associated with associated impact on quality of life can be significant, especially in those with darker skin. So we can see patients with fair skin, they don't have a lot of differences, and when they got darker, they have big differences between the disease and the normal skin. So surgical treatment is an important modality which was first reported by Huxton and colleagues in 1947. So it is very old procedure, but many modifications have been done to this. So we'll be talking first about this procedure, MKTP, which is melanocyte keratinocyte transplantation in vitiligo. So different modalities have been used. So we have the cellular type, we have the tissue type where we take the tissue itself and transplant it, and also the culturing the cells and others. So surgical therapy is considered a good choice in stable, localized, and segmental vitiligo. So if you have patients with widespread disease or extensive or active disease, usually they don't respond well to this procedure. We'll go for some updates from literature. This article is a systematic review looking for donor to recipient area ratio in surgical treatment of vitiligo. So simply, if you are doing this procedure, if you take more skin, you will get better results. And this systematic review also make this conclusion more stressed. So we have pooled analysis in this study showing that the ratio 1:3 expansion ratio, so that means you are taking a big skin, will give you better repigmentation when you do the procedure. Also, this study, they compared different diseases with the same procedure, and it was showing that therapeutic approach of these diseases is usually showing results in patients with other diseases. Like if you have patients with burn or other hypopigmentary disorder, usually they have better results as they don't have autoimmune disease. Also, the preparation of the recipient cells. So recipient cells, some of the physicians, they prepare the recipient area with CO2 laser. And in this article, it was showing it is almost the same result when you are using ablative or fractional CO2. So this is one of the patients that I have, and you can see here she's having segmental vitiligo, and we can see only 3 months she repigment almost 80%. So the message behind this, if you have patients with stable segmental vitiligo, usually they respond good. Also, this is another patient. You can see he's having segmental vitiligo again, and he came follow up after almost 4 years. You can see it's almost cleared, and he came also a few months back, and you can see he's maintaining the repigmentation. Here is another patient. You can see after 2 months, she's showing reasonable repigmentation in the forehead area. And this is just to show you, if you have patient with segmental vitiligo, especially in the face, usually they respond well. So we talked about vitiligo now. What about the other depigmentary disorder? Paludism, we know it is a rare depigmentary disorder where the patient, they have poliosis, which is white hair, plus the leukoderma, and surgical intervention considered a good option for this condition. I had many patients that we treated them with like eczema laser, with oxyrelin or phototherapy. Usually they don't respond well. So in a retrospective study, they included 5 patients with paludism, and it showed very good repigmentation results. So this is showing us that the patient with stable leukoderma, which is one of them is pybalidism, usually they have better results than vitiligo, especially if it is extensive, because they don't have any autoimmune reaction. Here is a study that was done on patients with pybalidism, and they compared either to use the cultured melanocyte transplant versus non-cultured. And you can see here clearly that the cultured showing better results. So the message, if you have big area, either pybalidism or vitiligo, it's better if it is possible to do it with cultured, so you can get more cells and better repigmentation. What about post-burn leukoderma? Many patients with burn, they are not bothered by scarred self, they are bothered by the depigmentation, especially if the patient, they have stigma about vitiligo and depigmentation. So, post-burn leukoderma is characterized by chalk-white depigmented lesions with disappearance of melanocytes, which appears at the site of burn and remain unchanged subsequently. And these patients, usually, they don't respond well to the medical treatment of vitiligo. So several surgical methods, such as chip skin grafting, very thin grafting, punch grafting, have been used for this disease, but still, I think melanocyte transplant will be the best regarding the repigmentation and the color match. In one retrospective study, they included 10 patients with leukoderma post-burn, and in those patients, most of them, they got more than 90% of repigmentation. And you can see here before and after. So we have this patient with burn. We are concentrating in depigmentation. This is after. And even if the patient is having overacral area, which is difficult to treat, usually they respond better than vitiligo. So the message is post-burn leukoderma, usually they respond well to the transplant. Here is another study, also again they did for patients with burn with very good results even in the area with acral area. So in such patients, usually I combine it with other treatment, like if the patient is having keloid, I inject like Kinacort or 5-FU, and if they have they are complaining of wrinkling of the skin, sometimes I add CO2, but you have to combine different treatments to get better results. This is one of my patients. She came after she got burned in this area, and you can see here excellent results, even only 4 months. So usually when I treat them, I give them oxyrelin with sun exposure or excimer laser if available. Also, this is another patient. She was complaining of this depigmentation because of burn. We can see here in the middle of treatment, she's having hyperpigmentation because of oxyrelin, but after a while, usually they return back to normal. So usually I tell my patients the hyperpigmentation is just temporary because of the oxyrelin. This is again another patient with burn. We can see here before and after, here before and after. Usually they repigment better than patients with vitiligo, as we mentioned. What about post-discoid lupus depigmentation? Although it's not common to have extensive lesions like this, what we are showing, but sometimes it's devastating. This is one of the patients. It was done with our colleague in the Center of Vitiligo in Riyadh, and we can see the patient is having extensive depigmentation that was treated and having better cosmetic results after that. What about the nevus depigmentosus? So it is a birthmark with well-defined, as we know, hypopigmented patch. The treatment usually include excimer laser, phototherapy, and skin grafting, but usually the treatment is not satisfactory. Even if we use melanocyte transplant, usually that treatment is not satisfactory. So for these patients, usually I don't recommend to do this procedure. Here, one of the cases done by our colleague in Riyadh, and you can see here the patient, she improved after 3 months, but unfortunately she has relapsed. So we have 2 issues here. The patient, they are not improving, or if they improve, sometimes they have relapse. This is one of my patients. She came to me. She's having nevus depigmentosa since birth. And I told her there is no effective treatment, but she insisted to do the procedure. So we did. This is after 6 weeks. This is after 3 months using phototherapy and with melanocyte transplant. This is 6 months, and this is the end result. So it is not perfect 100%, but sometimes the patient, they are lucky and they can get some results. So the take-home message is MKTP is a good option for stable vitiligo, post-burn leukoderma, and DLE depigmentation. In palbaldism, MKTP is having variable results. Nevus depigmentosus may improve with MKTP, but may reoccur later. So we don't recommend it to be done in this condition. That's it.
Thank you, Professor Saad, for the excellent presentation. I think we will have the Q&A at the end of the session. Thank you so much. It's a pleasure to introduce Prof. Sanjeev Handa. He's the head department of dermatology, venereology, and reprology in the Postgraduate Institute of Medical Education and Research in India. The floor is yours.
Thank you for the introduction. Well, friends, it's my pleasure to be here in front of you once again. And I have been asked to speak on subcutaneous mycosis cases from my practice. Well, I have no conflicts of interest and no disclosures to make. If we consider which are the commonest mycoses which we see as a dermatologist, we obviously all realize and feel that it's, of course, the superficial infections. But then once in a while in our clinical practice, we do get a case which leaves us, I would say, flustered. What exactly are we handling here? And subcutaneous mycosis, I believe, falls in that group. They are important to recognize and treat because they often have significant morbidity and mortality. I'm saying mortality. It may seem odd to some of you, but yes, that can happen once in a while. And they are mainly confined, we know, to countries which have hot, humid climates, that is the tropics and subtropics. They are generally caused by direct introduction of organisms through the skin. So hence, they are also known as mycosis of implantation, because trauma is a common history which we encounter. And they remain localized generally to sites of inoculation, may spread locally a few centimeters around the main lesion, but that's it. But atypical sites of involvement, extensive lesions, recurrent lesions, or refractory lesions should arouse suspicion in a clinician. What am I dealing with here? If we look at the classification of subcutaneous mycosis, of course, the commonest, which all of us know, is sporotrichosis, which we see. This may vary depending upon the continent that you are in. But then probably eumycetoma figures number 2. Then there are chromoblastomycosis, pheohyphomycosis, and the subcutaneous zygomycosis, both the enterothoromycosis and the mucormycosis. And of course, rhinosporidiosis, which probably ends up more with the ENT colleagues. Taking you to some of my cases. First case that I'm going to talk about was a 27-year-old female, and she had a total disease duration of around 9 months. And her presenting complaint was sudden onset of swelling of the right side of the face followed by epistaxis. After some intervention, the swelling progressed to increase in size with occasional epistaxis, that is, the epistaxis reduced, and later it became the swelling reddish hard and painful with stuffiness of nose and also watering from her eyes. She denied any history of trauma whatsoever, any procedures on the face, except as somebody had tried to interfere with the lesion, and she had no other complaints. And this is what she had on cutaneous examination. This was a gross facial asymmetry and disfigurement with the swelling on the right side of the face extending from almost the lower eyelid to the angle of the mouth. And she had almost a drop. You would feel the facial nerve is involved there. The swelling was well defined, hard in consistency, but had some areas of skin necrosis. And she also had a nasal mucosal examination done, which showed deviated nasal septum with inferior turbinate hypertrophy. The general physical examination, other mucosae, and systemic examination were within normal limits. Now, with this presentation, we were wondering, what are we looking at? And we had this differential diagnosis in our mind. The first was entomothromycosis or rhinofacial conidiopolomycosis, which is an uncommon subcutaneous fungal infection and produces generally painless swellings with grotesque deformity of the face. So now the odd point here was in enterothromycosis, if you would remember or recollect from your medical school days, the lesions are those under which you can insinuate your fingers and they are plaques, but normally they do not have an epidermal surface change. So our patient had an epidermal surface change. This set us thinking, are we missing something? So we kept differentials. Okay, let's keep a differential of aspergillosis and mucormycosis, because aspergillosis at times, the history of sinus involvement that was there, which we had at the back of our mind. And mind you, both aspergillosis and mucormycosis, they generally occur in people with weakened immune systems, and these infections can affect the respiratory system, sinuses, and other organs, and can be life-threatening. Aspergillosis can cause death because it causes the embolic phenomena inside the vessels. So aspergillosis, but we know, generally presents as bronchopulmonary aspergillosis or invasive aspergillosis, occasionally, or a fungal ball in the lungs, which is the aspergilloma. So the question here was, what are we having? Then when we started looking at what exactly the presentation features are, we realized that both have a similar sort of a presentation, except that on cellular morphology, aspergillus has a septate hyphae while mucor has aseptate hyphae. When we did our investigations, this is what we got. Acute angle branching on FNAC, slender septate hyphae, and on a skin biopsy we had moderate lymphomononuclear infiltrate with few proliferating capillaries. Now these proliferating capillaries also point towards a diagnosis of aspergillosis. And of course, like in FNAC, the granulomas with multinucleate giant cells with the presence of septate fungal profiles were there, and past staining was weakly positive. The CT head and neck showed opacification of right frontal sinus. So that means the sinus was also involved. Her HRCT chest also showed some changes in the form of calcified granulomas. I'm sorry, I don't have the pictures of the CT and the head and neck and the chest. We were now left wondering that if we are dealing with aspergillosis, why should a person who has no history of trauma, who has no history of any dental procedure except a procedure post-disease, develop aspergillosis? So we started working her up, and what we realized was she had a polyclonal gammopathy on serum electrophoresis. So this was the sort of presentation which we had, and we were led to a diagnosis of invasive aspergillosis with immunodeficiency. When we tried to read this up as to polyclonal gammopathy, we are still working this patient up. Many of these patients that I'm going to show you today, we are working up. We were wondering, does she have? Monoclonal gammopathy, you have a myeloma, you diagnose it, that's done and over with. Polyclonal gammopathy, you are left wondering what exactly could be the cause of polyclonal gammopathy. And anyway, that remains a question which is still unanswered even for us, and we managed her with IV liposomal amphotericin B for 14 days, and this is the post-treatment picture that you have, and she had significant improvement in her swelling, breathing, and her lacrimation also decreased as well. Moving on to the next case, this was a 35-year-old female, total duration of disease 10 years, similarly lesion presenting on the face, on this side, on the left side of the face with pain, and a waxing and waning course. And 1 year back, she had a sudden increase in size, and the lesion, she said, had ruptured onto the cheek. And when she came to us, she said 30 days back, this lesion has also ruptured inside the oral cavity into the mucosal surface. So we were left wondering as to what she had, which ruptures both onto the surface and inside. Normally, if I may ask any of you here, what would you normally think of when you get something like this? Actinomycosis comes to mind, oral cavity lesions rupturing on and rupturing inside the mouth. That's the commonest thinking. But anyway, she also had a surprisingly different, unrelated history, which was history of pain in both legs, which was gradually progressive and increased during walking. And this had been happening over the last 8 years. We did not give much cognizance to this, wondering maybe unrelated. And when we were asking her other histories, she gave no other history of any other comorbidity. She had taken multiple courses of antibiotics leading to partial resolution of her lesions, and she had also been subjected to some sort of a surgical procedure more suggestive of an IND. But there was no significant family or personal history. Upon examination, this is the type of lesion which she had on her face, and this was a diffuse, more ill-defined swelling with irregular borders on the left side of the face, extending almost from the zygomatic arch that you can see until the lower border of the body of the mandible, and involving the left half of both upper and lower lips. And this swelling was firm, non-fluctuant, non-tender, with no active discharge. A 5 centimeter sized scar with overlying hypertrophy was present over the left nasolabial fold, and a similar scar about 6 centimeters, if you can see, extending down from almost the zygomatic arch towards the mid-cheek, towards the angle on the left side of the face. And the rest of the general physical examination, mucosal and systemic examination, was normal. For this patient also, we had this sort of a diagnosis in mind. And with this, we did the investigations. Her complete blood counts, LFT, RFT, urine routine, and microscopic were all within normal limits. The FNA showed multiple epithelioid cell granulomas with few multinucleated foreign body giant cells, neutrophils, and lymphocytes. The PAS stain showed weakly positive fungal profiles with septation within the cytoplasm of the giant cells. The Gram stain was negative. PCR was also negative. On the biopsy, she had focal follicular plugging, focal basal cell vacuolation, and the dermis showed granulomas admixed with fungal profiles of both yeast and Eiffel forms. Now this is characteristic of sporothrix. So this is sporothrix. Normally, sporothrix we are used to diagnosing on the limbs, on either the lower limb or on the upper arm, with a differential of atypical mycobacterial infections, Mycobacterium marinum, whatever, those sort of. So this, for the face, sporotrichosis was a shocker for us. And when we started doing other investigations, we did the contrast-enhanced MRI of her face. We found a sheet-like soft tissue involving swelling, involving the left-sided subcutaneous plane, and also involvement of the left masticator space and left lateral orbit. Look at the invasion, but which was local. And the CECT showed chronic sinusitis. Her HRCT chest showed a few centrilobular nodules in posterior segment of the right upper lobe. There was no other internal organ involvement. The CT hip joint, to our surprise, showed avascular necrosis of both hips. We went back to questioning her, did you ever take steroids? We questioned her again and again, wondering that did any of her practitioners in the past, the physician she had been seeing, had they given her steroids? But she stuck to her history and said, no, I have never received any steroids. We did an immunodeficiency workup in view of no history of trauma at the site prior to onset of lesions, no interventions, no history of steroid intake, and AVN of both hips. And surprisingly, we found decreased CD19 lymphocytes and natural killer cells. And when we searched the literature, this was a shock for us. There was a report in literature, only one that we could come across, which said that idiopathic avascular necrosis can be associated with humoral deficiency. And when you have humoral deficiency, you are more prone to develop these fungal infections as well. So here was an unusual case in that the organism is common, sporothrix, but it's occurring at a site which is very strange. We would normally not consider that, and you need to depend upon your mycology colleagues to give you that diagnosis. So she had sporotrichosis of the left side of the face with B cell deficiency. Again, we treated her with IV liposomal amphotericin B for 14 days, and the swelling decreased, and this is her post-treatment picture that you can see, and the swelling is resolved wonderfully. And she's also being worked up for more immunodeficiency parameters. Sorry. Coming to case 3. This was a 42-year-old male who presented with a swelling over the medial aspect of the right leg since 1 year. And there was a history of gradual increase in size of the lesion over a period of time. And he also complained of a similar swelling developing on the posterior aspect of the right leg after about 6 months of the first one. But this patient had a difference. He came up with a clear-cut history of renal transplant in 2017, after which the patient was started on immunosuppressive treatment. So here we had an immunodeficiency background. There was no history of discharge, pain, redness, or bleeding from the lesion. In the treatment history, he told us that he had not taken any treatment for the swelling per se, but he was, of course, as a transplant patient, he was on tacrolimus, mycophenolate mofetil, Visolone, enalapril for his hypertension, metoprolol, clonidine, and for his renal disease. And this was his picture that we saw. The right lower limb morphology, he had two well-defined swellings, 3 by 3 centimeter and 2 by 2 centimeter on the medial aspect and on the calf of the right leg. These were non-transilluminating and overlying skin showed slight erythema. That was probably more because of the stretch to the lesions than anything else, with a little bit of perilesional erythema as well. On palpation, the lesion was mobile, cystic, non-tender, with no rise in local temperature, and it was not adherent to the overlying skin. So with this, we had some idea as to what could be the diagnosis. We did our investigations. The FNAC showed necrosis with nuclear debris and sheets of polymorphs, few foamy macrophages and multinucleated giant cells. No definite granulomas were seen. The PA stain showed slender septate fungal hyphae. This is the picture. On the left side of the screen for you is the multinucleated giant cell, and on the PA stain you can see the hyphae. And of course, this was surgically excised because that is the best treatment when you have localized lesions like this. And some of you would have been able to guess the diagnosis. So this was pheohyphomycosis. This is a cyst presentation in renal transplant patients, and those of you who have joint or collaborative sessions would have seen probably this case before as well. The lesions occur mainly on the arms and legs, and other less common sites include the buttocks, neck and face, and they may begin as papules which evolve into a cyst and may even lead on to forming large plaques. Surgical excision remains the treatment of choice. The medical treatment is of course amphotericin B, and if the patient can afford it, voriconazole as well, 400 milligram per day. Itraconazole and posaconazole have also been tried. It would also depend upon what sort of a background the patient has, which drug toxicities to avoid. So that would determine which treatment you would use in a particular case. Large or multifocal lesions require combined antifungal and surgical treatments. Antifungal therapy is recommended for recurrent cases and for immune compromised patients. The duration of treatment may change according to each case, so it is not fixed, and it is suggested to continue treatment for a month after the lesions have healed, or for 4 months if the lesions have been excised. So that means that for pheohyphomycosis, you have to give us a longish treatment. And to conclude, subcutaneous fungal infections can have a myriad of presentations, and they pose a diagnostic challenge to the best of clinicians. Unusual location, unusual organism, we must adopt a more proactive approach to investigation, leading to earlier diagnosis and more effective interventions. In recalcitrant, recurrent, or progressive disease and disease at unusual sites, please do consider immunodeficiency. Thank you.
Thank you, Dr. Sanjeev, for the interesting cases. And now we will shift to the next lecture. Dr. Sonja Mullen. She is adjunct associate professor of dermatology at Queen's University, Kingston, Ontario, Canada. She completed her training in dermatology and allergy at the Ludwig Maximilian University in Munich, Germany. The focus of her clinical expertise and research are inflammatory skin disease, mainly hand eczema and atopic dermatitis, contact allergy, as well as psoriasis. Please, Dr. Mullen, start.
Thank you so much for the kind introduction. Good afternoon, dear colleagues, dear ladies and gentlemen. This morning, unfortunately, I was not able to finish on time, and I apologize for any inconvenience. I'm very grateful to the organizers that I get a chance to show you the 3 slides and the 1 patient case that I was not able to show you this morning. And that's why, before we will talk about the many phases of contact dermatitis, I will briefly show you some additional data on delgocitinib. Now, remember this morning we were talking about delgocitinib cream as a new pan-check cream, new treatment options for our patients with moderate to severe chronic hand eczema. I showed you the phase 3 clinical trial data from the Delta 1 and Delta 2 trial, where delgocitinib cream was compared with vehicle cream, and later we saw some slides on the open label extension. But I think this trial is something you should see. This is some data that I found quite surprising when I saw it for the first time, and that's why I decided to bring it this afternoon to make sure you have seen it. So this is about the Delta Force trial. The Delta Force trial was a head-to-head comparison between delgocitinib cream and oral alitretinoin capsules in patients with severe chronic hand eczema over a time frame of 24 weeks. When I first heard about this trial being underway, I thought, oh, this is quite ambitious, a cream versus an oral treatment. But the results were very interesting, and they speak for themselves. Because when you look at the improvement of the HEXI, and we've been talking about the HEXI this morning, that's the Hand Eczema Severity Index, sort of like the PASI or the EASI that you know from psoriasis and atopic dermatitis. Delgocitinib was so much better than alitretinoin in these patients. And this is relevant for our patients, particularly also when we look at the safety profile. Because when we look at the safety profile, when you remember what we briefly discussed this morning for delgocitinib cream, there's really not much that stands out compared to the vehicle cream. Certainly not any concerning side effects, whereas we do see side effects potentially in a systemic treatment like alitretinoin. And I wanted to close this part of the lecture with a patient case of mine. This was a patient I've seen in the Delta trials, first in the blinded trial and then later in the open label extension. Has been a patient suffering from hand eczema for around 10 years, has tried various treatment options, including oral alitretinoin. Oral alitretinoin had been licensed in Germany since 2008 and also had been licensed in Canada since a few years later then. This patient has tried everything, and he was sent to me from one of my colleagues in private practice. She was about to start him on another course of alitretinoin, which helped him a bit but never cleared him completely. But she knew that we had the trial, and she said, maybe you can do something for him. This patient also had a diagnosed contact allergy to topical steroids. So topical steroids really were not an option for him. We were lucky that we could enroll him in the trial, and later in the open label extension, we knew for sure that he was on delgocitinib cream. And with this treatment, he cleared, and he stayed clear. And he was very excited about the treatment response, and I could tell because he gave me a hug at the end of the trial, which I thought was quite remarkable. And I've seen him just before I left Canada to come back to Germany, and the hands were still very well under control. So to summarize this part of my lecture, and again, thank you for the chance of allowing me this to present, to finish this. I think with chronic hand eczema, we have such a challenging disease. Our patients are suffering so much, and we didn't have much to offer until recently. And this will change in the near future, and this was important for me to convey this message. I also would like to speak a little bit about allergic contact dermatitis. And I would like to start off with a patient of mine. This was a patient I had seen for hand dermatitis or hand eczema for quite a bit in Canada. And her hands were, like the hand eczema was mostly on the palms, and it was quite chronic. Challenging case for this anyhow. But at one point, she came to see me in clinic, said, I have an acute problem. And all of a sudden, she had an eczematous flare in her face, on the backs of the hands, and in the V of the neck. thought, oh, this is unusual. This does not fit to what I thought of with her hand eczema. So what has caused this? And then I looked at her and I thought, this is an airborne distribution pattern. Phototoxic, photoallergic, sunlight, didn't really fit to the time of the year. Canada, is sunny in summer, but not always to the extent throughout the year that it might cause this. So I thought, okay, it really looks like allergic contact dermatitis. And what I really would like to offer my patient in this situation is do a patch test and figure it out and be able to diagnose. But I had to face a challenge because I was not able to offer a patch test. We didn't have patch testing at Queen's University at that point. We had to send our patients to Toronto or Ottawa, which is each a 3 hours drive away, and for 3 times a week, not feasible. So still, I had my patient and I wanted to give her some guidance on avoidance. So what I did is I tried to do a thorough history to understand what had changed in her life. And the only thing she told me was everything was the same, but her husband had painted the walls in the bedroom. And then I realized that my culprit allergen here probably is MCI-MI, so methyl isochlorothiazolinone and methyl isothiazolinone. These are preservatives. They are very commonly found in a lot of sources. Often it's in things we use to wash our hair, our body, our faces, our hands, or our laundry with. But they can also be found in wall paints. And I asked her specifically to figure out which wall paint her husband had used, and we were able to identify MCI and MI in those paints. Still, I couldn't offer a patch test, but at least I could tell her, I think this might be your problem, so please avoid this. Now, when I prepared this talk, I thought about how challenging it was often for me in the beginning in Canada when I wasn't able to offer a patch test and still wanted to do some counseling. And I have thought about patterns of clinical presentations that led me towards the allergen that has been causing this. And that's what I want to cover today. I want to talk about the 5 W's of contact dermatitis. What is it? 1 slide. Then who is at risk? 1 slide. Why should we try to identify the allergens? And what can we do? And what are the patterns? Well, allergic contact dermatitis is an immunological reaction. And I mentioned this morning that there is different immunoprofiles depending on the allergens. It always needs a sensitization and an elicitation phase. Who is at risk? Well, we all are. To some extent, some people are more at risk if they have risk occupations where they are exposed or where they have skin irritation or an atopic predisposition. Also, smokers seem to be more exposed. Why should we try to identify? Well, it would be nice to avoid the allergen so that with the hope that the skin disease or that the dermatitis calms down. Sometimes that's not possible, but at least we can try. We would like to give good recommendations for skin care and protection, and we would like to suggest alternatives. How to identify? Well, in the ideal world, it would be the patch test. I love patch testing. I think this is a great tool if it is available. But if it's not available, what do we do then? And when I thought about this presentation, I found a very good publication that I also will cite on one of the next slides that is about clinical patterns. And today I want to speak about clinical patterns, mostly face and scalp, eyelid eczema, hand eczema, and foot eczema. I'll just show you some pictures. Scalp and face, there are certain patterns that can guide you towards the possible source. For example, rinse-off pattern. So if the dermatitis is on the side, it's very clear it must be something that was used on the head, maybe also in the face, and it was rinsed off. This is why we have developed the dermatitis here. On the other hand, if we have a hairline pattern, very likely the cause is something that we did to the hair. Maybe a dye, maybe a perm. What about the face? Oh, I'll go back. What about the face? You see it below there. Airborne pattern, something that flies through the air that touches the face. also photoallergic pattern, and I thought it's interesting to keep in mind that the airborne pattern spares the nose, whereas the photoallergic pattern includes the nose. How about eyelids? We see so many patients with eyelid dermatitis. And the eyelid dermatitis, I think most common reasons why people have dermatitis around the eyes are either endogenous, due to an atopic predisposition, a reaction to things that fly through the air, direct contact, like what we apply around our eyes, indirect contact, when we touch our eyes with, and like transfer something that we do to our hands and our nails, and then very rare cases where someone is like working with crushing pills and has the drug dust in the eyes, like in elderly care nurses and so on. There's also some patterns that can be helpful. One is the drip pattern. You see under the eyes. This is usually a sign that they might be reacting to their eye drops. Or around the eyes, the contour pattern, where they react to the things we use around the eyes. Hands, well, hand eczema is complicated, and I think it's very difficult really to conclude from the morphology towards the trigger, unless you look at two specific patterns. One is the glove pattern, and one is the periungual pattern. So glove allergy, you really can see that because it manifests on the backs of the hands and on the wrists, whereas the periungual pattern around the nails really is related to the things we do to our nails. And then lastly, the feet. On the feet, the most prominent pattern is the shoe pattern, and if we see the shoe pattern, it's a good guide or a good hint that they might be reacting to something in their shoes, like for example the dyes or the potassium dichromate that we use to manufacture the leather. So think about the shoes when you see a pattern where the top of the feet is affected. So when to think about allergic contact dermatitis, when we have a very chronic and relapsing and very persistent course of the dermatitis. Think about contact dermatitis when we have specific distribution patterns, the ones that I introduced to you today, when there's a risk occupation, and also when the symptoms improve during vacation. That might be a hint that this is an occupational contact dermatitis. Just going back to the patient case I showed you before, the lady with the airborne distribution pattern, after a couple of years, I was able to finally offer her a patch test. And you would not believe how curious I was to see whether my hypothesis, when I could prove my hypothesis that she's allergic to MCI-MI was true, and it was. So I was able to confirm this contact allergy. Thank you so much for your attention.
Thank you, Dr. Sonja. And the questions will be after the lectures.
Okay, great.
And now for the next speaker. So our next speaker is Giovanni Pilacani, world-renowned skin and cancer expert and scientific director of SLKIP. Professor Giovanni is the chief of dermatology at La Sapienza University in Rome, Italy. He is one of the founding fathers, virtual biopsy with reflectance confocal microscopy, it's called RCM, and clinical applications and terminology as we know it nowadays. He is the author of several hundred of books, publications, and dermatology textbooks. And he was the president of the 2019 World Congress of Dermatology in Milan, Italy. So Professor Giovanni, the floor is yours.
Thank you so much. So here I'm going to introduce you a bit of a technology that is rather new, but I think interesting and new for the potential clinical application that can come in dermatology. Here we have actually not one technology, but we have two technologies that works on the same principle. So they works on the mechanism of confocalization of the light. That means to have a capability to give a very high resolution after a tissue is hit by a laser beam and it is reflected, and with this possibility to have a valuation of the tissue with a cytological level of the solution. There are the two technology. One is in vivo, that is usually used for evaluation directly on the skin for getting a diagnosis, a histological diagnosis, and then to take the decision, especially in tumor, to excise or not to excise. And the other application is ex vivo, so it's done in the course of surgery in order to decide if the margin is affected or not, or to getting a quick histological diagnosis similar to extemporary biopsy. Concerning the in vivo technology, we have a different evolution of devices. Today we have two devices, one for a big mapping of the tissue and one that is very rapid exploration with the handheld machine that gives you the possibility to explore the skin up to the upper dermis, let's say 200 microns in depth, with a cytological resolution, but black and white and a transversal section. For the rest, it really corresponds to the histopathology. So you have a histologic vision, but from a different perspective. This helps a lot for skin cancer diagnosis, because majority of skin cancers happen and arise here in the junction and in the epidermis, especially in the early stage where differential diagnosis is most difficult. So with this technology, you can observe the same structure that here, for example, you can observe in histopathology with this technology in vivo directly on the skin. For example, you can detect pagetoid cells. That helps a lot for melanoma diagnosis. You can detect junctional disarrangement and atypical melanocytes proliferating in the junction. You can detect the melanocytes forming aggregates, nests, like we can see in histopathology, but just black and white, but directly in vivo for good diagnosis. So where confocal helps? For sure, when we are not sure, not confident of our diagnosis, and we want to get from confocal more information to take a better and more precise decision. This is a typical case. We have lesions that sometimes are atypical, not enough to be sure that it is a melanoma, not enough to be sure that this lesion is for sure benign. So if we are in doubt, usually we excise this lesion, and this accumulate a burden of unnecessary excision, especially in patients with many molds. With confocal microscopy, you can distinguish the two differential diagnoses in one case because you have aggregates of atypical cells and atypical cells, whereas in the other lesion, it's silent. You have just normal melanocytic nest with no atypical cells visible. And this could be a very good help for making a good diagnosis. It helps a lot in my daily practice on lesion on the face, because on the face, patient doesn't want to get it out. They come to your office because they want to remove just a pigmentation, here a tag on the skin with laser cryotherapy with something aesthetic, so they don't want to get a biopsy. And if you propose a biopsy, the patient will run away. With confocal microscopy, you can detect the cytological atypia and can get a diagnosis of lentigo maligna even when they are very little, very tiny, and very difficult to be diagnosed. The same for basal cell carcinoma diagnosis. It's also one very easy diagnosis because you can see the tumor contour. Like in this case, that is a papule on the nose with actually not clear dermoscopic features. I don't see anything special, just this, let's say, translucid papule. I don't get it well with clinical and dermoscopic examination, but in confocal, you can see very well tumor island, so you know it's basal cell carcinoma, and you go with surgery. So these are, in skin cancer, the best application for confocal microscopy, and this application can really help you to reduce the number of unnecessary excisions. We demonstrated this recently in a randomized clinical trial that showed that we can save almost 50% of excision of benign lesion without not missing a melanoma. So the combination dermoscopy plus confocal microscopy is a super tool in order to make a precise diagnosis of skin cancer, avoiding the majority of unnecessary excision. I want to take the last few minutes for talking of a really interesting tool, ex vivo confocal microscopy. So even if the technology is the same, the application is another story. It's completely different. This tool is like a box with a stage where you put your slide of fresh tissue, and you have on the screen the projection of a histological image. So you take a section, you take out a piece of tissue, skin, but not only skin. It's all been done in other solid organ like prostate, kidney, breast, pulmonary tissue, etc. And you get a rapid histology on the screen. How it works, how can be used in dermatology? In dermatology, for sure, the application is to get a Mohs technique without the burden of the lab and without the time-consuming preparation of the tissue that you usually need with that. With this technology, you just need to have acrid in orange, that is a dye, very cheap, not expensive, in order to generate fluorescence in nuclei. So how it works, you have a skin session. You put it on your device and you get a picture that usually is generating a reflection from reflecting structure, like collagen. Then you can add on it the fluorescence of the nuclei that is highlighted by acrid in orange and the second laser beam. And then you make a digital transformation in order to attain a picture that looks like our normal hematocele eosin histology. So it's really a good approach in order to get it quickly, because you don't need much time. You just need to take the tissue, dip it, wash it, dip it in acrid in orange, wash it, and place on the machine. I would like to give you a little show on how it works in real life. So you take your tissue, you just dip it few seconds in acrid in orange. It could be a slice in the Mohs surgery, it could be a session that you cut from a tissue of any organ, so it works very well for the skin, but it's not only for skin application. You put on your slide, you prepare, it's like a sandwich because you have to flatten the epidermis onto it, so you put sort of blue tack that is stitching material, or you can use now glasses with magnets, make a sort of a pressure, and then you put this on your stage and you launch the visualization, so prepare it on the stage, and then you start the scanning of the tissue. Just a bit of gel, and we are in. Then it makes a scanning, and you can see appearing on your screen the histopathological picture. This is the advantage. It takes 2 minutes, and then you get histologic session present on your skin. Then you can explore, but also it's digital. You can send it to a pathologist for getting a digital diagnosis, digital confirmation. For example, it's tumor-free or there is a tumor involvement on this margin in basal cell carcinoma. So to sum up here, with this, you can have a digital histopathology in a very rapid time, and you can get the tumor margin, tumor burden quickly in order to, let's say, accelerate your evaluation and accelerate your pathology examination. That is one of the biggest difficulties to make Mohs surgery in some areas. So this is the indication, and I think that today we are the lab of a pathology is like this for Mohs surgery, for like this tomorrow, it can be like a box because it accelerates a lot this evaluation. I just want to conclude to invite you to Rome. It's a beautiful city, and we will have the International Congress of Dermatology June 18-21 this year, and you are all welcome to be there. Thank you so much for your attention.
Thank you, Professor Giovanni, for nice lecture. Later, the discussion questions. Next, now the last topics with Dr. Saad Talabi. Again, he will talk nice topic about vitiligo. We are interested for this new technique. Welcome, Doctor.
Good evening again. So now we'll be talking about how to prepare your clinic for melanocyte transplant. So many of my colleagues, when I discuss with them this procedure, they face difficulties in preparation of their clinic. So I hope this presentation can help in this. Nothing to disclose. So as we know that vitiligo is the most common acquired hypopigmentary disorder, and surgical therapy is considered one of the options. So these are the different types of vitiligo surgery. So if you don't have the setup or the time or resources to prepare your clinic for melanocyte transplant, you can go for tissue grafting. So all these procedure is simply to take the normal skin and you put it in the vitiligo area after preparation with like CO2 or with a surgical razor. So if you will do micro bunch skin graft, this is what you need. You need the motorized or the regular bunch that you use in your clinic, the small bunch, and forceps. If you will go for more simple, use just the punch graft, the manual one with forceps. But the main issue with this is, as we know, cobblestoning. So different colors, shades will appear in the patient. MKTP or melanocyte keratinocyte transplantation. This is the most common that I do in my clinic. As you can see, you need different tools and different materials that I will talk about it later. And split thickness graft, as we said, you just take the skin and you prepare the recipient area with CO2 or dermabrasion and you transplant. So what equipment or resources are required in a clinic to perform MKTP? So MKTP procedure needs a well-equipped clinic setup and specialized staff. But the beauty of this, if you train your staff and you get the equipment once, you don't need to do anything more later except some of the disposables. So the clinic setups, you need clinic general, let's say general clinic setup and special equipment and material. So you need comfortable procedure room where you can put the patient and you can move around the patient in all directions to make your procedure easy. Also, you need some simple surgical kit. You need betadine, you need lidocaine, you need simple like scissors, gauze, and so on. So this is, I think, available in all clinics. Now we'll go for the special equipment. So once anesthesia have been administered, the donor skin is obtained by utilizing the dermatome. So this is what is preferred by most of the physicians. So dermatome is used by plastic surgeon, by dermatologist, where you can determine how much of skin or the depth you will go. Sometimes you can use only simple plate. So in my clinic, I use this one, this plate. You just, with the needle holder, you can just take very superficial skin graft, and with time, with training, it will be easier and easier. So once the donor skin has been obtained, it's placed in Petri dish, and we mix it with trypsin. So the idea of trypsin, as you know, that it will dissociate cells from each other and separate the melanocytes from others. And we keep it in the incubator with 37 degrees for almost 50 minutes. Then we put it in the tube and in the centrifuge. So at the end, you need the cells to be down and the fluid will be up, and you collect the cells. So recipient area preparation in my clinic, I use this, which is motorized dermabrasion, and I like it because it is very safe and cheap. Some physicians, they prefer to use lasers. So you can use erbium laser, you can use CO2, fractional CO2, and so on. For the recipient area, we have two options, either the collagen dressing, but sometimes it's not available in all clinics. Usually I bring it from India. And the beauty of this, it will keep the cells in place. So this is a very nice type of dressing, or you can use simply gauze with Vaseline if you don't have this type of dressing. For the donor area, usually we use the hydrocolloid to decrease the pain and to absorb the fluid coming out. Sometimes if you don't have these, let's say, equipment, sometimes you can simplify this procedure, and I will just go through some ideas for procedure simplification. So this is an article was published a few years back in American Academy, and it was showing using simple blade that will give you the same result of using dermatome, and still I'm using this in my practice. Also, this article, it was showing that when you take the donor skin, you don't need to put trypsinization and you keep it in incubator. You just smash it and you end up with what we call it paste-like, and you just apply it over the recipient area. Here is another interesting idea. It was published in 2021, and was showing using the patient axilla himself as incubator, because you need 37 degree. If you don't have the incubator, you just put the tube under the axilla of patient for 40 minutes while waiting in the clinic, and that's will be enough to separate cells. So let's go for the steps of MKTP. So this is the equipment as we mentioned previously. So after doing anesthesia for the donor area, usually we choose the thigh. You can choose any area that patient prefer, and we take the skin using the simple blade. After that, we cover it with colloid and hydrocolloid dressing and simple secondary dressing. For the recipient, after that, we take it to the incubator, as we mentioned, with trypsin, and then we prepare it, we put it in the centrifuge, and we end up with, this is the solution that's containing melanocyte and keratinocyte. For the recipient area, after anesthesia, we use dermabrasion to prepare it until we see pinpoint bleeding, and then we apply the cells that we got it, then we cover it with collagen dressing. You can see here the transparent dressing, then cover it with secondary dressing with gauze and tape. So this is how we can take the skin. We just apply simple gel, and with the blade, you can see here we got the skin itself. And for the recipient area, this is the motorized dermabrasion. You can see with the preparation, you will end up with removing the epidermis, and you end up with pinpoint bleeding. So this is how it appears after the dermabrasion. So this area is ready now to apply cells. We apply it and cover it with dressing, as we mentioned. How to avoid complications? As any procedure, we have many complications. One of the things that usually I advise not to use epinephrine in your anesthesia, because if you use it, this will mask the bleeding that you needed, because you may go very deep and you end up with scarring. So usually use plain lidocaine in your procedure. Also, when you are working around the eyes, I don't recommend to use the motorized one. You have to use the manual way to avoid, sometimes it will flip and go to the eye itself. Also, if you are around the eye, like in the cheeks, usually we don't go parallel to the eyelid, we go perpendicular, because if it is flip, it will go in this way or that way. But in this case, it may flip and go toward the eye. So this is very important to avoid serious complications like injuring the eye. And that's it.
Thank you so much, Prof. Saad, for the excellent presentation. We would like to bring all the speakers to the stage, and the floor is open for question. I have a question for Prof. Saad. There is a risk of co-obnerization with vitiligo. So did you have that, any complication from the donor side?
Yeah, this is very important. Regarding co-obnerization, one of the criteria before we do the procedure is to ask the patient about the stability history. So the patient, he should be stable at least for 6 to 12 months. And in these cases, usually we don't have co-obnerization. Even in other procedure, patients of vitiligo, sometimes I do for them CO2, I do other procedure. As they don't have active or any sign of activity, it will not cause.
Thank you.
Can I have another question, Doctor? Dr. Saad?
Yes,
About the quantity, how much quantity from the fluid you will disperse on the area? Like there is some equation or
Like you mean the
now
donor
the
to
suspension,
recipient?
yeah, the suspension to the recipient area. How much quantity you should disperse?
Yeah, usually when we take, it's in the literature they said 1 to 10. Like if you have 100 centimeters square, you will take 10. But recently they showed more skin is better. So usually I take 1 to 3. So if you have like 3 centimeter of the area you want to treat, take 1 centimeter, one by one, and you prepare it with the cells.
And then the liquid which is prepared.
You
how
mean the
much is
liquid
it?
itself?
Yes.
Yeah, the liquid, unfortunately, there is nothing standard. But what I do in my clinic, before I prepare the suspension, I bring normal saline and I spread it in the recipient area. And I estimate like how much I need, like 0.1 or 0.2. And I ask my nurse to prepare this suspension.
Thank you.
Welcome.
Test. What about remote phenomena? We see remote phenomena in the transplantation. Like if you treat some area with depigmentation, another further area recolor itself automatically.
You mean
We
like
can
the patient, they will have active disease and they will have other
Yeah,
area?
remote phenomena.
Yeah, okay. So if the patient, usually when we do for them the procedure, first of all, it should be limited, area. So the patient usually they don't have active disease, but I tell my patient the possibility that they may have other lesions because it's an autoimmune disease. So the best results and satisfaction usually with segmental vitiligo. This is the best. Or patient with small lesions, but you have to tell your patient that it may reoccur in other areas. But recurrence in the same area, it's usually very low probability.
Thank you.
Any more questions? With that, we conclude this session.
One
We would
second.
Oh, sorry.
My question is to Dr. Sanjeev. Two of your patients had primary immunodeficiency. I deal a lot with primary immunodeficiency and skin. In our region, we don't see defungal. We see all odd. How often you see defungals? Although it is highlighted in the literature.
A very interesting question.
Yeah.
We have not been able to classify their primary immunodeficiency per se. We are still working on this, exactly where does it fit, number one. Number two, this is a specialized group of patients that we are recruiting now, where we are having these unusual organisms turning up when we were not suspecting them. That means at a site where we were not suspecting them. So this is definitely uncommon. So that was absolutely the precise intention with which I presented, that when you get this sort of an unusual presentation, your index of suspicion
One
has to be
innovative.
high.
Yeah,
Yes,
it's very
exactly.
interesting because this is what happened with the mycobacterial diseases when
Exactly.
patients' granulomas were getting active
Exactly.
bacteria, and now we know the link with STAT1 mutations and with other underlying immunodeficiency problems. Interesting.
That's why I said in my third case, which was a classical, we know that renal transplant patients have few hypomycotic cysts on the body. So that was okay. But for the others, it was a surprise for us.
Thank you. Thank you.
With that, we conclude the clinical update session. We would like to thank our distinguished speaker for tonight and have a lovely evening. Thank you.